Assalamu alaikum, everyone.
Assalamualaikum. Assalamualaikum.
Yeah, now I can see everybody. Wonderful.
Okay.
Walaikum salam. Thank you very much for the invitation.
We will just start in a minute.
Sure. मैं slides यहाँ से share करूँगा?
जी, if possible, और अगर नहीं तो फिर उज़ैर can share.
No, I can do that. Yeah.
Sure. Assalamu alaikum. My name is Kiran Amir and I am the Director of Operations at PARSA ECHO Pakistan Super Hub. I would like to welcome you all to our second session in the new ECHO series on inflammatory bowel disease. And it's in collaboration with South Asian IBD Alliance, SAIA, a charitable organization in the United States with a global presence in South Asia, India, Pakistan, and others. A special thanks to Genex Pharma for the unrestricted educational grant. Today's session is titled IBD Epidemiology, Etiology, and Pathogenesis. Our expert for today's session is Dr. Asad Rahman. He is a staff gastroenterologist, associate director, GI Fellowship Program, Cleveland Clinic, Florida, USA. Before we move forward, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation, so you can unmute yourself for questions or use the raised hand option or chat box. By participating, you have given the consent for recording, and the recorded session will be available on our YouTube channel. Link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number and email is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of the spokes, the session is bilingual. Please speak in Urdu, English, whatever language you are comfortable in. If you are interested in PARSA ECHO Pakistan publications, please fill the form shared in the chat box. I will now hand over to Dr. Jalpa Devi, GI Fellow, Liaquat University, Pakistan, for introducing SAIA and Dr. Asad Rahman. Over to you, Dr. Jalpa.
Assalamu alaikum, everyone. My name is Dr. Jalpa Devi, and I'm a GI Fellow alum. And I would first like to introduce South Asian IBD Alliance. And let me share my screen first. So, as you all know, South Asian IBD Alliance, it's the first patient clinician-led non-profit organization in the IBD space, with the dramatically increasing numbers of IBD in South Asia.
I'm sorry to
Dr.
interrupt.
Jalpa, we can't see your slides. Can you share again?
So you have
Okay,
to share it again.
let me share it. Now, are you able to see that?
It's in process.
Yes,
Yes.
now.
Okay. So, I would like to introduce, first of all, South Asian IBD Alliance. That is, SAIA is a patient clinician-led non-profit organization in the IBD space. With the dramatically increasing numbers of IBD in South Asia, SAIA has formed to create resources, research, and education for IBD patients and healthcare providers of South Asian origin to minimize disparities, dispel stigma, promote early diagnosis, and improve access to treatment. And its structure and goals currently it has 3 arms: that patient outreach and advocacy, professional development, and research. So SAIA's Professional Development Committee has partnered with PARSA Trust Project ECHO to educate general practitioners and gastroenterologists thoroughly about IBD, its pathogenesis, epidemiology, and how to provide the best care and treatment options to patients in a resource-limited settings in South Asia. And you can have contact through search the contents on the website. Also can connect through the social media accounts, that's Facebook, Instagram, Twitter, LinkedIn. And if you want a support group for IBD patients and caregivers, you can give the Facebook group that is run by the IBDs, and that is SAIA's patient advocacy team. And also, if you have any questions, query regarding SAIA, you can email them. And now I would like to introduce Dr. Asad Rahman, and who has been graduated from Khyber Medical College, Peshawar, then did an internship, and then did FTPS internal medicine at Jinnah Hospital, then moved to USA for training and completed his internal medicine residency from Advent Health Orlando, where he served as a chief resident as well. And then he did his fellowship from Cleveland Clinic, Florida, and served as a chief fellow. He has great interest in inflammatory bowel disease and medical education. And he is clinical assistant professor of medicine as well as associate director of gastroenterology fellowship program at Cleveland Clinic, Florida. And over to Dr. Asad Rahman. He will be teaching us about epidemiology, etiology, and pathogenesis.
Thank you, Dr. Devi. Can you all see my slides and hear me clearly?
Yes, we can.
Okay, thank you. So, Assalamu alaikum, everybody. Thank you very much to the PARSA Trust as well as to SAIA for this opportunity to speak on a topic that is very close to my heart. And I think as a Pakistani expatriate in the United States, I think something that we probably have a different experience and a different perspective of a disease in Pakistan compared to the United States. So I was asked to give a talk on the epidemiology, etiology, and pathogenesis. It's a very loaded topic, and I was given 20 minutes, so I'll do my best to do justice to this, but I'll try to touch upon the important things about all these different aspects of inflammatory bowel disease, especially about how this pertains to our population in Southeast Asia. All right, so first we'll talk about epidemiology. I was asked to be bilingual in this talk, so I may थोड़ी सी मैं उर्दू भी बोल लूंगा बीच में. I'll also converse in English. So if anybody has any questions, feel free to stop me in between the talk as well, and I think there may be some time at the end for some questions. So we talk about inflammatory bowel disease. This is comprises ulcerative colitis and Crohn's disease predominantly. And this is a disease that was initially thought of as a disease of the West, of people in Europe primarily, or in North America. But then as our urbanization has occurred in different parts of the world, we've or maybe better healthcare services have occurred as well. We've seen a significant rise in the number of cases in the East as well. There are significant variations. We see a lot of variation in terms of incidence and prevalence within Western countries and within Eastern countries as well. However, the divide between the two has significantly decreased. In the West, we see that ulcerative colitis and Crohn's disease predominantly affects both genders, both men and women, almost equally. A little bit more trend in women as far as Crohn's disease is concerned, but different studies have given different results. But more or less, the gender divide is not seen as much. But the data that we have in terms of incidence as well as prevalence of IBD in Eastern patient population, especially in Eastern Asia, we see that a lot more men are involved with inflammatory bowel disease as compared to women. Now, inflammatory bowel disease, like any other immune-mediated diseases, tends to affect younger people more, and that's what we initially thought. However, there is now a bimodal pattern of disease where we also see a first spike in the first, maybe second, third, or second or third decade of life, and then another peak maybe in the sixth or seventh decade of life. We are seeing that as well in Asian patients as well, but more so in the West, we are seeing a significant increase in the rise of elderly onset inflammatory bowel disease over the age of 65. I practice in Florida, which is a state in the United States where a significant number of people who've retired and over the age of 65 live here, and we are seeing a significant increase in the number of inflammatory new onset IBD in older patients here. So this is a graph that I took from Gil Kaplan's paper on the epidemiology of inflammatory bowel disease. What this tells us is that in the Western world, I mean, they have had records of inflammatory bowel disease for a long time. they actually divide different stages of epidemiology. They talk about emergence, acceleration, and incidence, where there's a significant increase in incidence. Then there is a state of compounding prevalence, where the incidence has stabilized, but because of the long-standing nature of disease, the prevalence progressively increases. And ultimately, it equilibrates, which is the fourth stage, which is called prevalence equilibrium. जो हम देखते हैं Western world के अंदर, when talking about Europe, North America, we are seeing that they are at a stage where the incidence has more or less stabilized. But now, because this is a disease that can affect very young people and they live for a long period of time, the prevalence has progressively increased over time. So they're in a stage of compounding prevalence, which is the third stage. Newly industrialized countries. Now, these are countries that include parts of Eastern Europe. They talk about India, China, I mean, probably Pakistan to a certain extent as well, but we are seeing that they are actually having an acceleration in incidence because of urbanization, because of change in their lifestyles, etc. And then comes the developing countries, where actually there is an emergence of inflammatory bowel disease. So these are the four stages that are described by Gil Kaplan, and basically this is elaborated in this world map as well, which tells us that basically if you see areas in Europe, for example, and also in North America and Australia, they're actually at a stage where the incidence has stabilized and now the prevalence is kind of going up. So it's called the stage of compounding prevalence. They haven't reached the last stage yet, but again, they're on their way. In majority of the world, including South America and significant portions of Asia, they're a stage where there's significant acceleration in incidence, and Pakistan is included in this, and so is India. Unfortunately, we don't have a lot of data available for epidemiology in Pakistan, so therefore these maps are actually based on best estimates. But again, it tells us that as our lifestyles have changed, and probably we're able to identify patients better, we have better diagnostic abilities now, we have better access to healthcare now, we're actually seeing a greater incidence in inflammatory bowel disease in this part of the world. So in terms of incidence, this graph is actually taken from Saw Ing, who is a prolific researcher in epidemiology of inflammatory bowel disease from Hong Kong. And what she talks about and what she looks at this in a world map, which is a different world map now, it actually looks at the published incidence of inflammatory bowel disease. And that's where Pakistan is grayed out, because we don't have great epidemiologic data that tells us what is the incidence of inflammatory bowel disease or prevalence. It tells us that the United States is one of the highest incidence of inflammatory bowel disease in the world. And if you look at Asia, I mean, because we're talking about our South Asia, we can look at data from India, for example, and in India, this is one of the highest incidence of inflammatory bowel disease as is being seen in India and Asia. I mean, and it says up to 9.31 per 100,000 patient years. Compare that to the United States, which is over 10 cases per 100,000 patient years. Unfortunately, we don't have data from Pakistan, so we cannot extrapolate ourselves directly from India. But again, India has significantly industrialized in their I mean, progress in medicine has significantly gone up. So therefore, I mean, although our incidence may not be that different from them, but again, I think it will be a little bit lower as compared to India. Also, if we see China, there is a significant increase in incidence in China as well. And also this variation depends on the part of China that you're studying. I mean, it sometimes takes a trend where the trend is a little bit higher in the southern parts of China compared to northern parts of China. So prevalence, in terms of prevalence in North America, there is, as I told you, because we are in a state in the United States, predominantly, there is a stage of compounding prevalence. So the prevalence has progressively increased. And it's expected that maybe until 2030, 0.6% of the entire population would potentially have the diagnosis of inflammatory bowel disease. That's a significant number of people that exceeds 2 million people at that point in time. Similarly, in Europe, in parts of Europe, up to 0.3% of the European population would have estimated to have inflammatory bowel disease in the next few years. And we see that the gap between East and West is narrowing. What I mean by that is that there is a significant greater population that resides in part of Asia. I mean, India and China have population that exceeds 1 billion people. So again, even if their total prevalence and incidence is less as compared to parts of North America and Europe, the absolute numbers, I mean, in terms of patient volume for inflammatory bowel disease is actually significantly narrowing as time goes along. As far as global prevalence goes, that's where we don't have a lot of data in Asia as well, because a lot of the studies that are coming from Asia, they talk about data in the last 10, 15 years, and they mostly talk about incidence. But I think as more and more data will be published in the next few years, we'll have more accurate estimates of prevalence of inflammatory bowel disease in Asia. So far as published data is concerned, we see that the United States, Canada, and Asia, and Australia, they have a significantly higher prevalence of inflammatory bowel disease, as they are in the third stage of the natural epidemiological cycle of inflammatory bowel disease. Again, same thing. In Pakistan, we don't have a lot of data. I wish that we will have collaborations between large hospital systems, because we don't have large registries available in Pakistan. It's going to be hard to have an accurate estimate on the ground. I think that big hospital systems, for example, Khan and certain large centers in Punjab, they can have a collaboration about, they can have an epidemiological study about patients who come in and basically seek care in large hospital systems, where we can actually have a real time assessment on the ground about the incidence and prevalence of inflammatory bowel disease in Pakistan. But to date, we don't have that data. So moving on to the second part of my talk, which is about etiology and pathogenesis of inflammatory bowel disease. Risk factors, if we look at that, they are divided into three main things. There are genetic factors. It's an immune-mediated disease, so it will have immune dysregulation. And that stems in part from an altered response to gut microbiome. Now, as far as genetic factors are concerned, I wish it was very easy where we could have a monoallelic pattern of disease development. However, we see that in Crohn's disease and ulcerative colitis, both of them, there is a significant number of genetic changes that can potentially be implicated. What we usually call that is that genetic changes are permissive. They are not absolutely required for the development of inflammatory bowel disease. We see that patients who have first-degree relatives with inflammatory bowel disease, either Crohn's disease or ulcerative colitis, their risk of having Crohn's disease or ulcerative colitis is significantly higher. Studies have shown a wide variety in terms of how many fold. It could be 5-fold up to 20-fold increases for development of IBD. अगर आपके पास एक पेशेंट है जिसको inflammatory bowel disease है, and if they ask you what is the risk of inflammatory bowel disease in their offspring, I mean, the risk could be as high as 5% in their kid as well, especially if only one parent is involved. If there are other family members with Crohn's disease or ulcerative colitis, the risk would be higher. So studies have been done where they have mapped the entire genome. They're called genome-wide studies that basically look at different alleles and different mutations, and they have been studied as risk factors for inflammatory bowel disease. One of the first genetic changes was known as NOT2, which is now known as CAR15. What that this genetic change or this allelic mutation was associated with was development of ileal disease, which is predominantly stricturing in type. So these we were seeing in a lot of patients who were actually with stricturing small bowel Crohn's disease that led to subsequent risk of resection and surgery. However, when they looked at this type of genetic mutation in the Asian population, we didn't see that quite frequently. So therefore, it tells us that maybe the phenotype of the disease may be different in different parts of the world, depending on the environmental exposures, depending on their genetic changes as well. In the Eastern patient population, we saw the JW1 that was associated with early onset stricturing Crohn's disease. However, this mutation was not associated, or this allelic variety was not associated with significant risk for Crohn's disease in the West. We do know that how these genetic changes occur is that basically they affect the innate immune system. You know, we have the innate immune system and then we have the adaptable immune system. So basically, the majority of these genetic changes were affecting our innate immune system, our body's, regular structured immune system in terms of our response to different types of microbiomes. And we did realize that basically there are certain interleukins, for example, interleukin 10, which tends to tone down our immune response. There were genetic changes, especially in very early onset IBD, like patients who develop inflammatory bowel, like kids who develop IBD below the age of 5. They had a much higher risk of actually having, especially genetic changes, especially changes in interleukin 10. And therefore, in our pediatric gastroenterologists here, they also, whenever they have a very young patient with inflammatory bowel disease, they do genome-wide analysis, and these patients may be offered a bone marrow transplant as a treatment modality. We also know that interleukin 23, which is also a target for our therapies for inflammatory bowel disease, there are certain mutations that portend protection against Crohn's disease as well. So therefore, there is a wide variety of genetic factors that is implicated in IBD. this is only responsible for maybe 10% or so of cases as such. The rest of them have a significant number of environmental abnormalities that we'll discuss later. So then comes the second point, which is immune dysregulation and that response to the gut microbiome. It's a very big topic, but I think in terms of, for the sake of time, we'll divide it into four basic things. They include dietary changes, which a lot of patients ask about, exposure to antibiotics in childhood, including appendectomy as such, especially in early life, breastfeeding in the early years, and cigarette smoking. So dietary factors, I mean, here in the United States and also in Pakistan, I mean, I have seen patients who really specifically ask about if they did something wrong or whether they ingested something that led to inflammatory bowel disease. So in the West, there is this large cohort of patients. These are actually nurses that are actually part of the, New England, where there's a large hospital consortium that follows the nurses that were employed since the 1970s. And they have really looked at data over 40, 50 years. And this is called the Nurses Health Study. And this is a very, very big cohort of patients who have really shared their details about their dietary intake. And they are really following the course of life of these nurses to see what happens to them over the course of their life, not just inflammatory bowel disease, but cardiovascular disease, et cetera, as well. And what they have seen in this large health cohort is that, I mean, those patients or those nurses who basically have an increase in dietary fiber, especially natural fibers, they have a low risk of having Crohn's disease, but not ulcerative colitis. The major three things that are basically considered as dietary risk factors here in the West include, lack of fiber in the diet. They include increased processed foods, increased red meat, and basically processed sugars. And they did see that in the EPIC IBD cohort, which is another Western cohort, composed of multiple countries in Europe, basically looked at the risk of inflammatory bowel disease in patients who were having a higher intake of processed sugars and higher intake of red meat, and they did find an association here. The important thing is that this is an association, not necessarily a causation. In Asian cohorts, however, there was no major, in terms of the studies that have been published, we didn't find a statistically significant association between fiber intake and processed sugars and IBD onset. But it did show a slightly decreased risk of developing IBD in patients who had regular consumption of tea or coffee. In chai, a lot of people, drink this as part of their daily routine. But again, I just feel like the odds ratio is very close to 1, and it's not very high. However, it is not, it may have a protective role for all we know, but we don't exactly know how. So therefore, there are certain dietary factors like this. Majority of our patients, when they have active inflammatory bowel disease, especially if they're having a flare, we recommend that they have less fiber because of decrease in frequency of bowel movement. But again, in terms of protection for IBD, I think we should all encourage our patients to have decreased processed sugars and all that. But again, that practice doesn't have a lot of data for the East. It has data for in the Western patient population, but not so much for our patients in Southeast Asia. What about exposure to antibiotics in early childhood? Now, this is an interesting topic because in Pakistan, a lot of antibiotics are available over the counter. And a lot of times, patients have had exposure to multiple rounds of antibiotic therapies. There has been studies in Europe, for example, in Denmark. They looked at the risk of IBD in patients who got antibiotics for a prolonged period of time and found that जिन patients को long-term antibiotics, यानी कि multiple rounds of antibiotics मिले, उनके अंदर risk of inflammatory bowel disease was higher. However, in the Asia Pacific cohort, looking at data from Eastern Asia predominantly, they looked at and then they found that the use of antibiotics was actually a protective factor, which means that they would actually had a lesser risk of developing inflammatory bowel disease. So this is interesting. There was also data in the past that told us that appendectomy in early childhood was a protective factor to develop in terms of preventing ulcerative colitis in the long run. However, that data has not been replicated, and therefore, having an appendectomy in early years was not specifically a protective factor in other studies as such. So therefore, what it tells us is that there is discrepant data between the East and the West, and therefore, what the next question that comes to mind is that whether the disease itself, is similar or whether it has different features. And this is not part of my topic, but I think that is the question that next comes after, these differing types of risk factors. Breastfeeding, this is something where the East and West have similar data. It tells us that both in the East and West, in kids who are breastfed in early life, they had a lesser risk of developing Crohn's disease and ulcerative colitis down the line. but the magnitude of benefit was significantly higher in terms of in Asia as compared to the West based on their odds ratios. Why is it the case? Probably because, breastfed infants, they have a higher biodiversity in their microbiome, especially a higher number of firmicutes and actinobacteria. And therefore, because of this biodiversity, they have a lesser risk of developing inflammatory bowel disease down the line. Cigarette smoking. This is where Crohn's and ulcerative colitis are different. Patients with Crohn's, they have a significantly higher risk of cigarette smoking actually flaring of the disease. And also in active as well as passive smoking exposure led to a higher risk of Crohn's disease, more so for patients who develop Crohn's disease below the age of 30. However, we do know that patients who actually quit cigarette smoking, they subsequently have a little bit of a higher risk of developing ulcerative colitis. However, we did see that, prior history of smoking was also associated with UC in Asian patients, with Australian patients in the large access cohort of patients. So therefore, there's also some similarity in that, and in terms of cigarette smoking being a significant risk factor for Crohn's disease and both the patient population, as well as former cigarette smoking being a risk factor for development of ulcerative colitis in both cohorts. What about physical activity and environmental hygiene? There is some data that suggests that the more active you are, there is a lesser risk of developing Crohn's disease down the line. Again, these are large epidemiological studies that are all associations, not necessarily causations, but we did see that people who are more active, they have a lesser risk of developing Crohn's. Not so with ulcerative colitis. Now, data from China, from Korea, and Japan, it also tells us that access to adequate hygiene from the environment, for example, access to having a toilet that has a flush in it and access to hot water, these data tell us that if patients who had access to these environmental hygiene things that basically we consider part of a normal life, they had a lesser risk of developing ulcerative colitis. Similarly, we did see that patients who were actually exposed to pets early on, which is a little bit paradoxical, but when they were exposed to pets early on in their life, the risk of inflammatory bowel disease was actually lower. So this is a Venn diagram that I created, basically looks at the comparative risk factors or comparative factors in etiology between the West and the East. And we see that in the West, the cigarette smoking part that we discussed about, the appendectomy reducing the risk of ulcerative colitis. However, this has not been replicated in other studies in the East. Antibiotic exposure actually increasing the risk of Crohn's disease comparing to a decreasing incidence in the East. Significant increase in processed sugars and low fiber diet being a risk factor in the West, but not so much in the East as such. But we did see that the common risk factors are breastfeeding, especially for more than a year's time, decreases the risk of IBD in both cohorts, more so in the East as compared to the West, and having pets exposure early on in life also leading to a decrease in IBD. Whether that affects the microbiome, we do not know that. But again, these are the differences and similarities in terms of risk factors for development of IBD in East and the West. And the last part of my talk, I hope I have a few more minutes. I'm going to present just two diagrams, basically looking at the pathophysiology of IBD. This is very complex, and I'm not sure if I'll do justice with it in the next few minutes, but I want you to understand that this is a very complex interplay of environmental factors, genetic factors, and response to microbiome. This diagram I took from the New England Journal paper on IBD pathophysiology that was published in 2020. जो पहली diagram है उसमें हम देख रहे हैं कि this is what normal looks like. What does normal look like? We have microbiome that is in the lumen of the bowel. Normally it has, there are billions and trillions of basically types of bacteria. We have some fungi, we have parasites in there, and in some patients that actually occupy the lumen. Now, whenever there is abnormality in there, whenever there's decreased biodiversity, that may play a role in pathogenesis. Then comes the mucus layer that is produced by the goblet cells within the intestinal epithelial lining. And this mucus layer also gives a physical barrier for entry of microbiome and other abnormal stuff from coming into the epithelial lining as well as going down deeper. On the surface, we see different types of cells. There are basic intestinal epithelial lining cells. There are Paneth cells at the lower end that produce antimicrobial proteins. There are basically dendritic cells that actually catch the antigens from the surface of the bowel and then take it inside to the body's lymphatics and immune system. There are certain lymphocytes that actually line the lumen, line the intestinal lining. And of course, I mean, there is IgA, which is produced by the plasma cells in the deeper layers and it actually gets translocated across and gives a chemical kind of a antagonistic effect to any microbial invasion. Now, whenever there is an exposure to something abnormal by the dendritic cells, these dendritic cells go down and go to the surrounding lymph nodes. And essentially, normally, it's a complex interplay. Normally, this happens when normal circumstances, there is an immune balance, which actually tries to balance the risk of having an invasion from something like that's an infectious source and trying to tone down the inflammatory response that actually leads to IBD. So there's a balance in there. And the most important interleukin that I see in that is called interleukin 10, that actually is produced by the T regulatory cells, or the Treg cells. And that actually tones down the immune response so that the immune response is not super aggravated. That doesn't involve activation of neutrophils, activation of other macrophages that can produce TNF and other molecules. So this is usually kept, in check. However, an inflammatory bowel disease, there could be multiple things, and that's why when you have treatment for IBD, it treats different parts of this pathophysiological mechanism. There is microbial dysbiosis. Whether this is the chicken or the egg, we do not know. However, we do know that in certain patients, if there was actually a trial there was actually two trials that were done where they looked at fecal microbiota transplant in patients with IBD, and they had conflicting results. And therefore, it is not standard of care to actually give FMT to all patients with inflammatory bowel disease. It's only approved for patients who have C. diff infection. We're not there yet where we've actually identified what kind of microbiome to actually transplant, but I think there is basic science studies that are being done, especially for certain strains of Clostridia species, like 17 species have been isolated that in mice, actually, if the mice who had inflammatory bowel disease, once this kind of bacteria were actually introduced into the lumen of the gut in those mice, the IBD went into remission. So therefore, we are trying to fine tune that, as it has not translated its way into real life medicine yet. Then comes the mucosal lining. We see that in patients with IBD, there is a significant dysregulation of the tight junctions. We see that more and more of these of the microbiome, both normal and abnormal, are able to cross the intestinal barrier. They are crossing from the lumen all the way onto into the deeper layers of the intestinal wall. And therefore, these antigens that are being presented to dendritic cells ultimately make their way down into the mesenteric lymph nodes. Now, when these dendritic cells make their way into lymph nodes, they actually drive T cell differentiation. There are naive T cells that are lying in the mesenteric lymph nodes. And they actually, because of the significant increase in the antigenic load that they're getting, it's getting primed into development of Th17 and Th1 cells. These are effector T cells. And these T cells, once they go from the lymph nodes, they go into the bowel wall. Because of increased expression of alpha-4 beta-7, which is a target point for treatment of like vedolizumab in treatment of inflammatory bowel disease. They go into the bowel wall, they cross that through the endothelium into the bowel wall itself, and subsequently they cause release of multiple interleukins like interleukin 17, interleukin 21, gamma interferon, etc. And this mediates an inflammatory response. It also leads to activation of neutrophils. Neutrophils are part of a body's innate immune system, and that leads to significant inflammation. And that's what we see a lot in our patients with when we do biopsies of our patients with IBD, we have significant neutrophilic infiltrates, and we see, when they make their way across into the surface of the bowel wall, they can cause crypt abscesses and crypt architectural distortions. When macrophages get activated, they lead to increased production of TNF, interleukin 23, interleukin 12, interleukin 6, and they significantly, affect the overall architecture of the bowel as well. And this, when this number goes significantly up, especially in Crohn's disease, we see development of granulomas, etc. We also see a significant shift between IgA and IgG. We see that usually in normal health, we have a lot more IgA producing plasma cells in there. When that switch happens between IgA and IgG being a complement binding immunoglobulin, it leads to a significant activation of complement cascade and more inflammation happening afterwards. And therefore, there's less IgA and more IgG in inflamed bowel as such. And this diagram, although it's complex, it allows us to identify certain targets for treatment. We talked about, changing microbiome. We're not there yet in terms of therapies, but we look at the activation of the T cells and their differentiation into Th17 and Th1. That's where the JAK inhibitors come into play, like tofacitinib, upadacitinib, basically they're targeting this pathway. When we talk about interleukin 23, there are two subunits. There's the P40, which is targeted by ustekinumab, and now recently approved medication in terms of IL-23 more so. It's called risankizumab, and guselkumab is in the work as well. When we talk about the P19, there are a lot of trials going on with the P19 subunit. We don't have any drugs that are clinically available who can target the P19 subunit of IL-12. We see that those lymphocytes, for them to leave these lymph nodes and go into the bowel, they need to really bind to the endothelial cells. And therefore, the S1P blocker or Xanamod comes into place to prevent egress of these activated lymph nodes outside from the lymph nodes into the bowel. And then alpha-4 beta-7 inhibitor vedolizumab is also used that actually prevents lymph nodes from coming into the bowel as such. And of course, I mean, the oldest biologic that we have, anti-TNF, they're very potent. I mean, they block the effect of TNF produced by the activated macrophages. They're very potent. I mean, there are several of them that are approved for both Crohn's disease and ulcerative colitis. So therefore, this diagram tells us the different opportunities in terms of therapy that we have for patients with inflammatory bowel disease. So what are our take-home messages? I'll finish here, and then I'll take some questions if there are any questions. That epidemiological studies tell us that IBD, which used to be a disease of the West, is now a global problem. Its incidence and prevalence is changing in different parts of the world. We do need data from Pakistan to understand how much of a disease burden we have in there, and hopefully have better treatment options for our patients. Traditionally, I mean, describe risk factors like processed foods, I mean, all that stuff which is associated with urbanization has not really translated its way on epidemiological studies done in the East. But again, these may not be applicable for everybody who develops IBD in the East. And that tells us that we need more data in terms of describing the phenotype of diseases between West and the East. And then in terms of pathophysiology, there's a very complex interplay between types of microbiome changes, the genetic alterations that lead to development of inflammatory bowel disease, and then the immunological response and targets that we have identified to really treat inflammatory bowel disease, and understanding of that is very important. We must realize that, I mean, the immune system or the GI immunology is about 75% of the body's immune system. So we are just beginning to scratch the surface of it. And the more we are able to identify specific targets, I mean, we have been able to create more therapeutic options for our patients. So I hope this was helpful for you all. I mean, this was a lot of stuff that I was trying to cram into 20 minutes or about 15, 20 slides. And I'll be happy to answer any questions or elaborate on anything that you guys didn't understand. Thank you very much for your time.
Thank you, Asad. I'm another Asad from Gujranwala here, and it's great to see you. It's a wonderful talk. To be honest with you, I learned a lot. और मेरे ख्याल में पाकिस्तान में जो हमारा target है with SAIA, and I'm very grateful the help from Janix that we have been able to pull out this program. और inflammatory bowel disease हम ये समझते हैं ये बहुत neglected और probably ये इतना नहीं. Before any question, we have Professor Altaf Alam here, who is also our course director and teacher of many of us who are present here. He was ex-head of department, Sheikh Zayed Hospital, doesn't need any more introduction. Altaf Sahab, I'd like to hear from you, and then we'll go towards question and answers.
Thank you very much.
Thank you. Thank you both, Asad's really a wonderful talk. And the interest you can see by the participation. Around 90 people are attending this session. So a great tribute to you. And also the interest that we have in this country on IBD. Very little knowledge, but a lot of interest, because we are also seeing a surge in incidence, and the prevalence is rising. As the facilities are becoming more and more available, we are able to diagnose the cases that we were unable to diagnose previously. So thank you very much for taking time out and enlightening us on this very important topic of on epidemiology, pathogenesis, and etiology of this complex disease. So I hand over to Dr. Jalpa Devi to ask any questions that have already been asked through the text messages, or if not, she can take it over from here. Dr. Jalpa, please.
Thank you, Dr. Alam. Sorry to interrupt, but again, it was a pleasure, actually. Very nice to have you in the audience. You will not remember, but I was a fourth-year medical student I did my elective with the GI department at Sherzad Hospital in my medical school. But I think it is, for me, it comes full circle. I mean, I consider you my teacher, and it's very nice to actually have you in the audience. I did also work with your son, Umar, in Jinnah Hospital as well. So wonderful.
Thank you. Thank you.
Thank you so much, Dr. Altaf Alam, great teacher. And I would like to ask from audience if they have any questions.
Jalpa, Asad, there again, there is a question. It was very interesting to note ये जो antibiotics का आपने जिक्र किया, क्योंकि पाकिस्तान में आपको पता है, आपने mention भी किया कि यहाँ पे तो हमारे पास हर पेशेंट एंटीबायोटिक खा के आता है, और जो एशियन पॉपुलेशन है उसमें एंटीबायोटिक का आपने गालबन जिक्र किया कि बहुत, I mean, it was rather protective, you know, if I'm not wrong.
जी.
तो उसकी क्या वजह है? क्या हम इतनी इन्फ्लेमेटरी जो इन्फेक्शन इंड्यूस्ड इन्फ्लेमेशन है उसको इतना वक्त नहीं देते? पहले डायरिया पे यहाँ पे फ्लैजिल और सिप्रो चल जाती है, और उसके बाद कोई वेट भी नहीं करता ना, ये तो अब घर की माँ भी बता देती है कि तुमने यही खाना है. तो आप क्या समझते हैं, what's going on, or is there anything that we can do to maybe solve this riddle? जी असद.
So I think आपने बहुत अच्छा पॉइंट रेज किया. I think एंटीबायोटिक्स हमने ही बचपन में बहुत खाई हैं. जब भी कोई डायरिया होता था तो I mean, बगैर किसी डॉक्टर के पास गए हुए अम्मी से हमें फ्लैजिल मिल जाती थी, and then I think it would get better within a couple of days. I think इसका ताल्लुक जो है, इसका आंसर एग्जैक्ट तो या शॉर्ट अल्फाज में देना पॉसिबल नहीं है, being very very honest about it. लेकिन I think इसका ताल्लुक माइक्रोबायोम के साथ है आपके, क्योंकि I mean, when you get exposed to antibiotics, आपकी बायोडाइवर्सिटी इफेक्ट होती है. And then many times there's also this hygiene hypothesis जहाँ पे आपकी body का जो immune response है, that also, I mean, हमने pathophysiology में जिक्र किया, we have this regulatory T cell pathway that actually prevents activation of inflammation. And when I think because हमारे यहाँ चूंकि GI infection का rate कहीं ज़्यादा है as compared to the West, I think हमारी body का जो response है probably towards development of effector T cells, यानी कि TH1 और TH17 का ज़्यादा रिस्पॉन्स है, बॉडी उस तरफ कम रुझान जाता है. So basically, I mean, the likelihood of having an infection in the GI tract वो कहीं ज़्यादा है as compared to development of IBD. So I think उससे हमारा जो बॉडी का जो immune response है वो पहले ही tailored है towards treatment of infection. Antibiotics are just a response to whatever symptoms we are having, and I think उससे हमारे microbiome को फर्क पड़ता है. क्योंकि वेस्ट के अंदर एंटीबायोटिक्स का इतना ओवर द काउंटर जो कि नहीं मिलती, डॉक्टर के जरिए मिलती हैं. सो आई थिंक जो यहाँ पे मेजॉरिटी ऑफ द स्टडीज हैं, यानी कि जो मेयो क्लिनिक की जो ऑम्स्टेड काउंटी है, वहां से बहुत ज्यादा डेटा निकलता है. उन्होंने ये प्रूव किया कि भाई बहुत ज्यादा एंटीबायोटिक एक्सपोजर से यहाँ पे आईबीडी का रिस्क बढ़ता है. आई थिंक प्रॉब्ली यहाँ पे चूंकि जीआई इन्फेक्शंस का रेट उतना कम है, और आई थिंक मिस डायग्नोसिस हो रहा होता है उस वक्त, इन्फेक्शन नहीं होता, ट्रूली इन्फ्लेमेशन होती है, तभी वो मास्क हो रही होती है प्रॉब्ली थ्रू एंटीबायोटिक यूज. तो हमारे यहाँ probably it's about the rate of infections that we have. हमारे जो generally dysentery का रेट ज्यादा है, gastroenteritis, viral gastroenteritis का रेट ज्यादा है. So हमारी बॉडी का immune response tailored है towards, I mean, towards treatment of infection as such. तो उससे जो है हमारी बॉडी का जब एंटीबायोटिक्स एक्सपोज होते हैं, हम एक्सपोज होते हैं एंटीबायोटिक्स को, तो हमारा माइक्रोबायोम चेंज होता है, और हमारे अंदर यूजुअली नहीं होती इम्यून एक्टिवेशन की, जो कि यूजुअली वेस्ट में होती है.
Any other question?
you have the option of raising your hand, or we can unmute you and you can ask the question directly if you want, please.
There is a raised hand. ये एक मोबाइल Vivo 1906 है. आपका कोई क्वेश्चन है तो आप अनम्यूट करके अपना क्वेश्चन बोल सकते हैं.
I think if we have a little bit more time, हम इसमें बारे में ये बात कर सकते हैं कि जो disease itself है, Crohn's disease or ulcerative colitis, these are not, I want to also put this point across, लेकिन जो कि मेरा scope में नहीं था ये, these are not just two diseases itself. I mean, Crohn's disease itself, there are multiple phenotypes of that, and then also these ये differ करता है different parts of the world के लिहाज से. So there is also data जिससे ये पता चलता है कि जो Asian patients हैं, this is not a huge humongous data set as compared to the West, लेकिन जो patients हैं Asia के, उनके अंदर, although the type of Crohn's disease, यानी कि there are different types of Crohn's disease, कुछ होते हैं जिनमें सिर्फ inflammation हो रही होती है, कुछ में strictures develop करते हैं, कुछ में fistulize करती है disease. उसमें ये दिखा रहे हैं कि basically patient जो कि eastern patients हैं, उनके अंदर complicated Crohn's disease का risk ज़्यादा है as compared to the West. इसको सिर्फ surface, we have to take that data not just based on face value, we have to take that with a grain of salt. उसकी reason ये है क्योंकि the access to healthcare, which was originally there in the West, was a lot better as compared to the East. So therefore, it's probable that by the time the patient sought care with a healthcare provider, their disease was so far advanced कि वो disease ने अपना natural course ले लिया होता है. So therefore, it's hard to actually, equate that fact कि भाई East में जो IBD है वो worse है as compared to West के. Probably इसके अंदर इस बात का भी है, इस चीज की भी importance है कि access to healthcare कितना ज़्यादा है यहाँ पे, क्योंकि यहाँ पे West में whenever there is a problem, things get handled quite quickly. यहाँ पे पाकिस्तान के अंदर, for example, I know anti-TNFs are very expensive. Government के कोई ऐसा insurance का system नहीं है. So therefore, अगर किसी patient को कोई fistulizing issue है, कोई perianal fistulas का problem है, the likelihood of them requiring an ileostomy, the likelihood कि उन patient की surgery होगी, वो कहीं ज़्यादा होगी ऐसे country के अंदर जहाँ पे medication की access नहीं है as compared to West, जहाँ पे access है and you can actually prevent complications from occurring. So therefore, it's very fascinating कि किस तरह disease differ करती है in different countries and how हम चूंकि उस कर्व के अंदर, अभी हम इमरजेंस की स्टेज के अंदर है, हमारे पेशेंट्स केसेस बढ़ रहे हैं, हमारे पास उतना एक्सेस नहीं है, सो हमें हो सकता है जो हमें अब सिवियर कॉम्प्लिकेशंस देखने को मिल रही हैं, दैट इज जस्ट अ लाइकली कि वो पेशेंट बेचारा किसी पेरिफेरी के अंदर उसको एक्सेस किसी ऐसे डॉक्टर का नहीं है जो कि कोलोनोस्कोपी करके उसको डायग्नोज कर सकता है, एंड देयरफॉर द डिजीज कीप्स गेटिंग prolonged and complex as time goes along. That's also very, and also I don't know if there's any other question, but one more point about Crohn's disease itself. I think जब मैंने इसको शुरू में पढ़ा था, when I was studying that as a medical student in residency, I just thought Crohn's disease is very, very different than ulcerative colitis. As we saw more and more patients, ये देखने को पता चला कि Crohn's colitis जो है, that is a lot closer to ulcerative colitis in terms of its overall presentation and complications as compared to Crohn's ileitis. Crohn's ileitis is a very different disease altogether, and of course terminal ileum सबसे common location है for development of Crohn's disease, but again जो behavior terminal ileal Crohn's disease का है वो कहीं different है as compared to colonic Crohn's disease, and a lot has to do with the genetics, a lot has to do with the type of interleukins that keep getting activated. So basically the take home message is that don't just take those two diseases as two separate entities. आप उसको understand करें कि disease है किस तरह की, उसका behavior कैसा है, उसका inflammatory behavior है, उसका fibrostenosing या fistulizing behavior, rather than the location alone determining the treatment as such.
जी, thank you. मेरे ख्याल में यहाँ पे इस फोरम पे we have support from Janix और बहुत सारे doctors हैं. I can see we have a very good attendance today. यहाँ पे ये भी जरूरी है कि अभी हम जैसे जैसे प्रोग्रेस करेंगे to work on some system के किसी भी इलाके के nearest endoscopy facility कहाँ पे available है, so that they can be guided for diagnosis. जो बहुत ज्यादा हम देखते हैं क्लिनिकल प्रैक्टिस में अनफॉर्चुनेटली के जो मरीज हैं रिकरेंट डायरिया के साथ आ रहे हैं, उनको रिकरेंट ट्रीटमेंट मिल रहा है, एक एक 2-2 साल गुजर गए हैं और वो बेहतर भी हो जाते हैं, चाहे वो उनको हम देते हैं एंटीज, उनके जो है डायरियल दे देते हैं, उनको एंटीबायोटिक तो हर दफा मिलती है और कहीं ना कहीं बट डिजीज कीप सिमरिंग, दैट व्हाट आई बिलीव टिल सच टाइम के वो आता है कि मैं हर 2 महीने बाद मुझे डायरिया लग जाता है, 2-4 दिन रहता है, 10 दिन रहता है और फिर उसकी एंडोस्कोपी होती है, देन यू रीच के जी इसको तो ठीक ठाक कोलाइटिस हुआ है। तो यहाँ पे वी ऑल नीड टू वर्क, आई मीन अपार्ट फ्रॉम ये सारी एजुकेशन, मेरे ख्याल में यहाँ पे भी बड़ा जरूरी है वो लोग जो डिफरेंट एरिया से ज्वाइन कर रहे हैं, we can work hard to help them in diagnosis also। और ये भी एक मेरे ख्याल में साया का ऑब्जेक्टिव है, जलपा इज हियर, वो उसके बारे में ज्यादा बता सकती हैं। और मेरे ख्याल में सारे सेंटर्स में पाकिस्तान में एक अब बहुत अच्छी पेनिट्रेशन है इवन एट डिस्ट्रिक्ट लेवल हॉस्पिटल। जी,
I think also is also important कि हम collaborate करें between multiple centers ताकि पता चल सके कि इसका एग्जैक्ट इम्पैक्ट क्या है, बिकॉज हम पीछे हैं एज कम्पेयर टू आवर सराउंडिंग कंट्रीज इन टर्म, हमें तो अपने डिजीज बर्डन का ही नहीं पता। सो आई थिंक बड़े सेंटर्स, जनरल हॉस्पिटल हो गया लाहौर में, मेयो हॉस्पिटल हो गया, शेख ज़ैद हो गया, कराची के अंदर आगा खान है, एंड डाव हॉस्पिटल की जो हॉस्पिटल्स हैं, I mean there has to be a multi-center collaboration के उनको probably it's not going to be easy, लेकिन I think अगर ऐसा एक सेंटर, एक ऐसा सेटअप हो जिसके जरिए आपके जितने पेशेंट्स हैं जो आपके पास आते हैं GI के क्लिनिक के अंदर, आप उनमें देखें कि कितने पेशेंट्स को जिनको डायरियल इलनेसेस हैं या कोई GI कंप्लेंट्स हैं। क्रोन्स में तो कभी कभी डायरिया इतना होता भी नहीं है, मोस्टली एब्डोमिनल पेन और मैल एब्जॉर्प्शन के इश्यूज आ जाते हैं उसके अंदर। तो हमें कितने परसेंटेज को रियली इन्फ्लेमेटरी बाउल डिजीज है, और देन लॉन्गिट्यूडनली हम फॉलो करके देखें कि उनका बिहेवियर क्या था। क्योंकि देखें यहाँ पे तो आई मीन अनलेस यू आर वेरी वेल ऑफ, अनफॉर्चुनेटली गवर्नमेंट की कोई ऐसी अवेलेबिलिटी नहीं है टू बायोलॉजिक्स। बायोलॉजिक्स आर बीइंग यूज्ड वेरी कॉमनली है। इसका मतलब ये नहीं है कि सिर्फ बायोलॉजिक से ही ट्रीट होती है डिजीज। हमने प्रॉब्ली इज़ाथायोप्रिन और मेथोट्रेक्सेट को तो बिल्कुल छोड़ दिया। आई थिंक देयर स्टिल अ रोल ऑफ दैट, स्पेशली हमारे सेटअप के अंदर अंडरस्टैंड करना चाहिए कि कैसे उसको अप्रोप्रिएटली आई मीन डोज एस्केलेट किया जा सकता है, क्या साइड इफेक्ट्स देखे जा सकते हैं उसके साथ। लेकिन एपिडेमियोलॉजिकली हमें उसको एक्सप्लेन, हमें इस प्रॉब्लम को पहले मेजर करना है एंड देन आल्सो टू सी हमारे पेशेंट पॉपुलेशन के अंदर कैसा बिहेवियर है। एंड मे बी हो सकता है कि हमारे पेशेंट्स के अंदर अगर हम उसको अप्रोप्रिएट ट्रीट करें, हमारा भी जो आउटकम्स हैं वो सिमिलर हो हमारे जो हम साया कंट्रीज के अंदर है, वेस्टर्न कंट्रीज के अंदर है एंड ऑल दैट। सो I think it's a little bit difficult in Pakistan, but I think we are beginning to understand. I think this is a great initiative, and but I think we need better understanding कि हमारे यहाँ patients किस तरह के आते हैं, उनके behavior कैसा होता है, उनका longitudinal follow up कैसा होता है, ताकि हम अपना individual क्योंकि हम अपने plan उसके लिहाज से हम बना सकें।
जी, थैंक यू। ये एक कमेंट है चैट सेक्शन में, हमारे जो इन्फ्लेमेटरी बाउल डिजीज एको सेशंस हैं, डॉक्टर गालबन हाफिज जुबैर साहब ने पूछे हैं, ये मंथली बेसिस पे होंगे और आपको इंशाल्लाह एटलीस्ट 1 to 2 weeks बिफोर इसकी इंटीमेशन जो है वो आ जाए करेगी। एंड वी हैव आई थिंक इट्स 18 सेशंस हैं तकरीबन जो हमारे प्लान है। दिस इज द सेकंड ऑफ दोस। जी जलपा, ओवर टू you and Kiran for further question nahi hai to you can wind up.
Dr. Asad, we have Deputy Director Imran Hussain Saab online from Genex. If we can take some comments from him.
जी जरूर।
जी sure जी।
जी Mohammad Imran sir. Sir, you are muted.
Assalamu alaikum. Can you hear me?
Yes, we can hear you.
Okay. First of all, it is an honor and privilege for us as the Genex Pharma to collaborate with PARSA Trust for novel cause of sharing medical knowledge. And thank you very much, Dr. Asad Rahman, to deliver valuable experience and knowledge on IBD with your excellent command on the topic. It was really a good session. And last, Janice Pharma is thankful to Dr. Asad Chaudhary, Dr. Altaf, to give us this valuable platform to work with this noble cause. और इंशाल्लाह ये एक लॉन्ग जर्नी है जिसमें हम आपके साथ कदम ब कदम आगे बढ़कर साया ट्रस्ट के साथ और जो आपका पार्सा ट्रस्ट है इसके साथ जितनी लॉन्ग जर्नी हम कर सकते हैं वो जरूर हम आपके साथ करेंगे. थैंक यू वेरी मच.
Thank you.
Thank you.
Thank you.
I think so we will be winding up the session. और ये जैसे कि डॉक्टर असद ने बताया है कि this series is designed to have sessions once in a month. So keep joining us and be part of IBD series in the future. We are grateful and thankful to all the participants who have joined us along with our expert, Genix Pharma for the unrestricted educational grant, and our course director, Professor Altaf Alam Sahab, and team at PARSA ECHO Pakistan and SAIA. So Allah Hafiz from now. Uzair, you can call off the meeting. Thank you.
Sure, ma'am. I'm going to call off this. Thank you.
Thank you.